complete everything today, particularly the initial part, the primary survey and what exactly secondary survey mean to us. As we have discussed about the thing that ATLS is nothing but a new. Actually, it is the same treatment protocol we will continue in our day-to-day practice or in a standard hospital. But what is more important to understand here is that you have to prioritize. You have to prioritize in the sense that what kills the patient should get the priority. As I said already, suppose a patient is coming to you with a small injury in the hand. Cut injury, bleeding is there. But equally he is having difficulty in breathing. So necessarily your attention should not be focused on the area where there is small wound and there is a bleeding. But in common practice, our attention is invariably diverted to the area of bleeding or injury for where he is crying. It is true, but equally it is more important to understand that how he is taking the respiration. How his breathing is going on. How is the circulation? Let's get more priority than that of the small cut injury in the finger or toes. That is important. That is called priority. And the concept of whole has come from an incident that took place in 1976. He was an orthopedic surgeon. James Schrader was an orthopedic surgeon, and he made an accident in an aircraft, private aircraft actually, his own really. Then his family was there. Wife and 4 children. Then made an accident, then wife died. Then when he came to the hospital, hospital was closed. Then doctor was called. He came, he started treatment, but the inadequacy of the treatment at the time, what is needed, was very painful experience for spinal. And that is the beginning of a new era. Then he realized that if I can give so much treatment to the patient, now, why my children are unable to get the proper treatment at the time of need? That was the striking point. Then he has brought this matter to the actually he prepared himself. Then he placed the matter to the American Surgeon Association, and he was accepted later on, and his protocol was accepted. Then he is accepted, but then he tried to start this thing, concept there in America, later to Canada, then Europe, then throughout the country. As of now, today, at least more than 50 countries of the world is practicing this protocol. It is ever increasing. But for that, they have to have a tie-up with that of the American surgeon, because this is your intellectual property. So that is why, if you start here also ATLS, you cannot start it of your own. Though you know the technique, but you cannot start. You need to take the permission from the authority, and that will be monitored by you, as far as ATLS is concerned. So even in India, we do have the Apex ATLS training center is your Apex Trauma Center in Delhi. There will be AIMS. Apex Trauma Center. So there is a organized your apical center. There is a training going on. Of course, there are certain few private centers are also there doing up. But from in government setup, it is the apical center, where the training of ATLS as well as TOT is also being trained over here. Then pre-hospital training protocol for those who are not actually surgeons, medical doctors, but paramedical are also being trained up there. So that there are 3 types of training there. One is paramedical, another is for doctor, another is for TOT, training for the teacher. When you have to go for the training to teach. So that way you can continue, and that is why how it is being designed. And every year there is some sort of verification results there. What is being told in 2015, there are a lot of changes in this 2019 also. Something new coming up, something are abolished, which is not getting much priority. Nowadays, some new things are coming up which is actually causing, because this is a continuous process. They used to analyze, that is your analyze by doing so, they are trying to find out what is the mortality and mortality of this protocol. Then I found that no, some additional thing may say anything. Again, something is coming, something is out. I will tell you something happening during the period also. Some new things are coming out. As such, as of now, this is the way we go. So preparation, as I told earlier also, preparation of the patient, preparation of the yourself also, this is a very important thing. You being a doctor or service provider, this true you can serve, there is no harm. But the important thing is that you also take precaution for yourself. You cannot endanger yourself for the sake of your saving someone else or extending service. Yes, that is why, as I said, few examples are. So if you do not know the conditions of the patient, he may be a hepatitis B patient, or he may be a AIDS patient also, or he may be having communicable disease, and if you do not take any protective gear of your own, there is a possibility of contamination to you. Yes or no? One example I told you earlier also, there is somebody has made an accident on the road, and he started doing the resuscitation on the road itself, where there is a possibility of another accident may take place because you are in the middle of the road. So that is the preparation. Yes? Then also suppose the electrocution, the wire is falling on the car who is making an accident, made an accident on the electric post. The wire is falling on it. And if you touch it, this is necessarily there will be another danger. So this is called preparation. So that preparation is needed to protect yourself so that further incidents or further deterioration of the situation does not take place. That is the preparation. As you know, this is the prioritization, part of the prioritization. If the service providers are less and you need to give a low mass casualty, then it is necessary, true, that you cannot extend everybody's service. Yes or no? It is not possible for one to give at a time, and also initial period is very important. In this case also you have to segregate. Where to give the what priority? Should I give a person who is dying, or elderly person who is made an accident who is also in the person dying, but another young person who needs some sort of your cleaning of the mouth, where will you give the attention? Whether the person, elderly person who is going to die, or another young man who is having mouth covered by blood, where to give the priority? Because you have limited resources. That is trials. The concept of trial is a big thing, but the concept is this: where to give what priority. So that is called trials. Primary survey is the thing, is the most important. Primary survey and secondary survey, there is a difference between these two. The primary survey go along with the research. Actually, both things together going. Only survey is not. Then I am seeing the patient, okay, over. No, nothing like that. Whatever I see, you have to act immediately. So primary survey and the action needed for it is going simultaneously. It is not that I am seeing ABCD like this. No. Unlike in secondary survey. Secondary survey, that is a different thing. But primary survey, it goes simultaneously. Means whatever you have seen, you have to do. So that is primary survey and the secondary survey. The concept is a bit different in the sense. The secondary survey, you are throwing a throw in doing so, but these are not going to kill him. But it is necessary to find out what additional problem he is having. But primary survey is altogether different. Primary survey, you have to find out what going to kill him. And not only diagnosis, but you also act simultaneously. That means you assess it and act it. Assess and act goes together. Yes? So you are seeing the mouth is open, it is survey. Mouth is closed by or obstructed by some foreign material or blood or a broken teeth. Protein. That is okay, that is survey. But simultaneously what you are doing is the action. So in primary survey, the concept is you have to act simultaneously. It is not only the survey, it is also action simultaneously. That is why the whole concept between these two, these things actually goes together. And the main difference is exam to the primary survey is another additional things coming out. Few examples are that exam to it, once the patient is stable, in the primary survey you will need to go for X-ray. Now earlier concept is going for 2 X-rays. What I am talking is some modification. Every year there is some modification. Earlier days adjunct to the adjunct. Means in your concept you have to add cervical spine. Earlier concept only first. First is focusing to the area certainly by pericardium, liver, spleen and the bleeding. Now extension of this E first. Here you have to look for the chest also. And you say in sex examination, this is your whether hemothorax, pneumothorax or pneumothorax is better identified by the ultrasound. So this is extended first. So there is a modification. That means what we have been taught in 2013. I believe we did in 2013. How? 2013. Two trainings. There it was focused like this. Now it is extension, this modification. Yes, the evaluation, monitoring evaluation is important. Monitoring evaluation is a continuous process. That means what he is telling, okay, right now he is doing fine. Doesn't mean that after 1 hour he will be okay. May not. So that is why it is a continuous process. Continuous process is helpful simultaneously. Definitive care is a condition that where primary survey or secondary survey is being done, sometimes even without secondary survey. Two things are there. If you have this facility with you to give it, suppose here, if a hereditary patient is coming along with a flexor femur, so what you are going to do? You are going to do stabilizing this flexor femur and send the patient from other centers for neurological point of view. Yes or no? That is the concept. That is what exactly definitive care is there. So definitive care means whether you have this facility with you to give the final treatment, or if no, then what next? You have to stabilize the patient and refer the patient, a person or a hospital where he has the definitive treatment facilities are there. So definitive treatment depends upon the availability of your facilities in-house or out. There are certain your things are there. We have to follow how to refer the patient. If you have a normal patient, you need to differentiate in your field and in the pre-field and in actually pre-hospital and the in-hospital. Pre-hospital, as I said, many times is made by the paramedicals. Hardly there doctors are available. You may be saying in the corner place also some ambulance are waiting. They know that this is area where there is more accidents. Or even if you saw sometime in the national highway also, you may find a certain area that ambulance are waiting for it. So their paramedical staff is there. In the case of incidents, they will be in action. And here the concept of treatment and here the concept of treatments are also defined. So paramedical as such not encouraged to give any sort of medication. Of late, another concept is coming up. What is that? Anosmic acid. That is also being thought to be, yes, another additional thing. Pre-hospital, because bleeding is there, control is there, but what additional medicine can give to him, because you cannot continue the bleeding till he is coming to the hospital. Meanwhile, if the profuse bleeding is taking place, then what left? You can give fluid and other things, but compression and other things are there. But certain new concepts are also coming up nowadays that can you give out anosmic acid or something like that to hold the bleeding. So these are the new additional things. As of now, it is discouraged to give medications there. But they are also deal with the ABC only. A is your air breathing and C is control of breathing. And other parts is not in this purview of your pre-hospital. So pre-hospital is mostly by the paramedicals. So you do not encourage medications there. In the field preparation, coordination with these agencies are important. They are also trained person. They are also undergoing a training like ATLS course. And their training is a bit different than they say that medications are not encouraged. However, basic things are being taught how to save the life, particularly considering the ABC. So their question is airway, control of breathing, and utilization question. These three things mostly. So B also says there is problems or says compression is there somewhere, something is happening. They are doing something, but their main role is to play for ABC. ABC. So immunization with patients, and as I said already, the immunization with patients and transportation with patients, most of the time is being done with the what? Spine board. Spine board. Spine board is a device, as I said, that where one can immobilize the patient in a whole and total. So irrespective of any fractures, be a fracture of the femur, or be spinal injury or neck injury, anywhere, all the fractures, whatever it might be, for the transportation purpose, it is better to send the patient a spine board. A spine board is, have you seen ever a spine board? You have seen here, practically or in the diagram? Practically, how? And how many steps are there? How to hold it? You have the steps to hold the forehead, chest, body and leg. So this is why, I given an example also. Somebody in the fourth floor, the accident is there, and they need to suspend the patient or transport the patient from top floor to ground floor or to the ground. And you cannot come to the staircase, neither you can use the lift also. In these situations, how to bring the patient down from a top floor. So that is how the concept of your spine board. You hold it, you suspend it, you can really send the patient easily. So these are the things. So that is why spine board is an important thing, particularly in trauma situations in the transportation system. You may not have the facility by applying plaster slab or other things there, or trauma or other things for if there is a fracture also. But spine board takes care of everything. So that is an ideal choice of important, particularly in transportation of the patient from pre-hospital to hospital. So that is one. So immediate transport closes verified trauma center and field trial decision scheme. The expert, one team leader is always there, who will say who patient should be sent first. An interesting point is that those patients who shouts more should be cured. That means in a mass casualty, what happens? Those who have a small injury, they will come first. They can come themselves, and they are just creating the scenario. Attention is better ever there. Except those who actually need the service, they are still in the field. Those who used to come to hospital themselves and find there is least attention. Actually, they are not to be taken care of much. Those actually in the field still who are unable to come on their own actually need it. So shouters hardly needs treatment. Others who is still in the field actually need it. This scenario many times happen. So a small car will be coming early and he will create the scene. No, attention should be focused to the other part. That is why a field crash. It is also a who patient to be needed. So necessarily, if you have ambulance has a capacity of 10 person to live, you have a 50 patients in a field, mass casualty. Then necessarily you cannot transport everybody at a time. So who will be transported first? Will be decided by the person. And that person, those who will be coming first to you, hardly needs the attention to be there. He doesn't need care, but he will be first to be there. You remember? So that is the importance of the trials. So he may not need attention, but he will be coming first to the ambulance to be transported first. Yes, because he can come to his own. So drives is important. So those who need the attention to be drives and see the patients according to priority. That is your drives. So in the hospital phase, this thing is always being done by you. Actually nothing new is being taught. But thing is that you have to prioritize. The two scenarios may be there. One, that you have educated percentage with you. Yes. Then the scenario is defined. Patients are less. You have enough resources, money, manpower. Another scenario, particularly in hospital, while you go to hospital, you talk hospital in the tertiary care center also, hospital in the primary health center. The primary health center is how many doctors center? One? Yes or no? You have 10 persons coming. Yes, it is defined. Yeah, one is coming, 10 is available, 10 doctors are available. But in a primary or a secondary hospital, you have one or two doctors. Even ABC. But in a hospital, in a tertiary cancer area, where you have enough resources, enough manpower, there you have to divide the groups. To take care of A, take care of B, take care of C, take care of D, take care of E, like that. Yes? So all these things are, they have their own designated area. So if you go to Delhi sometime, you visit the Apex hospital, Trauma hospital. In the ground floor, you see the arrangement there. There are certain zones are there. Green zone, yellow zone, red zone. Red zone is the person who needs all this intubation and other things, more care. Green zone is hardly needs the care. Yellow zone is something in between. So there are zones. So once the patient is coming, they will be trice. Trice is done right. That trice is being done to say, oh, he is talking, he is okay, he is speaking, he is having injury, again. He is having flexor, he is yellow. One who cannot see, what is your name? Red. So first thing is the segregation in clinical setup is what? How you do this division? How you do? You divide this thing on the basis of talking to patient. First thing you ask him, what is your name? Where from you are coming? What happened to you? Now if he can give a good reply to you, if he is oriented, lot of things are explained. Yes? This is many times a trial, as I said. Many times is being done only speaking to the person. Once you are speaking to the person, then he just said, I am Ujjwal. I made an accident like this. I am coming for like this. Where are you? I am here. Everything is fine. What are the airway is okay. Breathing is okay. Because of which I can able to speak. Orientation is okay. Sensorium is okay. So many things are okay. But one who cannot speak, two things are there. One is fully unconscious. Another who is yes, another group. Another who cannot respond also. So you have to divide. So division penetrance trials is practically in this scenario is being done with this help. Yes? So the orientation otherwise is necessarily is not a person to be given more attention. One who is having stutter or stutter, unable to speak, his mouth is floated, needs attention. Yes? So that is how one can divide. So one patient is coming, so this is way. So one should need to go yellow, one need to go green, one need to go to red. So this is being divided. So accordingly you have to, so yellow, red necessarily means more attention, all the equipments and other things are there, including chest tubes and other things, whatever might be, can be done there. Yes? So intubations and other things will be there. So that is how. The resuscitation of properly comes in airway equipment. So airway equipments nowadays, how the patient is, once one is coming to you, what first you are doing for the airway? Airway first is cleaning the mouth. So in the while hospital he is coming in hospital, pre-hospital different thing. We have to clean it with the mouth. Nowadays of course many times hospital ambulances are also having a pump sort of your suction machine. That can be used to clean the mouth. Manual. Suction machine. Have you seen? Particularly newborn also you have seen. That is available. That can be done. Or you have to clean the mouth of your manually. One is jaw thrust and simple. Yes. Yes or no? A mouth cleaning everything. So that is mostly in hospital. In hospital what you are doing? In hospital you have the facility. What? You have a suction. You have a suction machine. So you have to have a big board suction machine, then you clean it. So it's not necessarily do your manually do remote meeting. So manually you must have a gloves or something else in the barrier. So that you directly do not put your finger inside to clean the thing there. That precaution should be taken. But here, since in hospital you have this facility, there is no point. Next thing is what? What next thing? Jaw thrust, pull, mouth cleaning, suction, then nasopharyngeal tube. Next step. If fail, then go for echo, thyroid, hold. Echo, thyroid and echo in between. Tracheostomy is a different thing. Tracheostomy is a permanent sort of thing. It can be continued for that. Or immediate if it is in between the trachea and the cord, in between. more is that that is being done. Third, what is second? Second is intubation. ঠিক আছে? So jaw thrust, cleaning, sucking, okay, fine, taking, breathing, okay. Unable to do nasopharyngeal tube, unable to do intubation tube, unable to do osteopathic एकदम finally tracheostomy sequence. So nasopharyngeal tube देखा? Nasopharyngeal, oropharyngeal from somewhere you have C7 one. You can use the measurement will be done from the outer tragus to tragus. This is length, so you have to put it. Initially concavity upwards, then you put it inside, then do rotation, so that you can put it. So the tongue which is falling back is most of the time is your culprit. So this helps it putting it. And in the hospital, irrespective of anything, while your patient is surgery, start oxygen giving early. Yes, so always should be given oxygen first. There is no harm doing so. So establishing an oxygenation. Establishing the tract by all this maneuver, sucking, cleaning, jaw, pulling, nasopharyngeal tube, intubation, tracheostomy or whatever. Sequence. Oxygen should be started. ঠিক আছে? So next one, chest. Chest of 1 to 3 to C. This is airway. The airway doesn't mean that he is taking breathing. So you have to go for the again breathing. So breathing or what? What you are going to do in hospital? Auscultation. Simple thing. Auscultation, percussion, teacher. So trachea is C. So if your air entry is equal both sides in hospital, you are very happy. Basic or base down in both sides equally coming after establishing this, you are very happy. But you are not happy. If you are not happy, then go for what? What next you will do? At this you will do percussion. Yes, you see your neck vein. Look at the neck vein. Look at this trachea. Do the percussions. Do the auscultations. That will exclude what? What happens in trauma situations? Most of them pneumothorax, flail cyst. Yes, pneumothorax. And this can be conclusively proved by what? With the help of the ultrasound nowadays. Because ultrasound is handy. So in hospital or in hospital, ultrasound always there. So one has to know ultrasonic picture, particularly how a pericardium looks for. Pericardial effusion is there, traumatic. Pericardial this is maybe done. Then what happens in case of if the air is not there, if pneumothorax is there, if the pneumothorax is there. So that can be done easily with ultrasound rather than going for X-ray. So X-ray will take place. So ultrasound you can do it again. You can ask someone to do it. You can simply see. So they can make it sure. Yes. So extended fast is being done to confront this situation is assessed while clinically you are in doubt. Clinically, auscultation both sides, air entry, good, very good. Not happy, then you find the stony dullness, oh, that means your fluid is there. Hyperresiness, oh, there is air is there. Both are there, that is pneumothorax. Yes, trachea is shifting, oh, that is another point. So that is necessary you have to do for tube. So next thing is your definitely one have to put a tube. You have to put a needle there to explain the pneumothorax, or you have to put a tape. Yes, otherwise your air is not going to do any research. You're good. So that is why it is action. Survey and action both things go together. Yes, properly functioning airway, as I said, these are the things. Sequence of event I told you, drug suction, or thing up to take as well. Then now fluid. Yes, it is said that in adult person which is coming should be infused more easily with caution. 1 liter of fluid. And it is said it is better to give short, big bore, IV needle, cannula in both anticultural, both sides. Both sides is said that can give blood, another side you can also go for another fluid. But what next? Next is that you do not give your attention only for the fluid. If the patient is not go for blood or blood products. Blood or blood products. This is a new edition. So in a hospital, you only do not concentrate to revive the patients only with the crystalline. And that crystalline should be given a warm one. Why? Because temperature is very important. You do not allow the person to go for hypothermia. So that is why one should keep an incubator is there. Incubators are there in the good hospitals. They used to. Otherwise, in our setup, you can warm water also you can give it, particularly in winter season. So if you give a cold, that the other go hypothermia. Hypothermia is not a desired thing in case of trauma situations or you're in shock. So you should give warm. And incubation maintains a definite temperature. That is how it goes. Sterilization is given, not improving. Do not wait for the other fluid to keep on and on to raise blood. Two things are done in this situation. Either go for the blood or blood substitute, or you have to find out where from the blood is losing. Yes, this is like a scenario like that. Scenario like that, your tank is there, water tank. Water is inflow, but equally your tap is open. Yes, it is inflow and outflow is going simultaneously. So what is retention? Retention is zero. Yes, so retention is zero unless you close the tap. So that is important. So you have to think that you are only pouring water, and equally if you are keeping the tap open, it's not going to serve your purpose. So you have to think of it. And also one point, additional point I would like to tell you here. Nowadays it is also important to understand that it is not only the coming and going one. Another thing is also happening. Somebody may be there with some medicine, like your aspirin for long time, anticoagulant. What is my point? So if he is on anticoagulant, it is nowadays said they give important data part, or most of the patients may be having that. So if you are only thinking on this line, giving and going, closing, probably may not serve your purpose if you are unable to address that part. Yes, so that is the history of this body also nowadays said. Maybe more important to save the price than the anti-drug should be given rather than going for this usual technique. Understood? So this is the additional thing nowadays. Earlier this concept was not there. Nowadays they are thinking. Then equally what? They are not speaking the same. Maybe it is. Yes, same. Nowadays these new concepts are also coming out. In this chest injury, another thing I will tell you, their plain chest should be considered as a very devastating situation. No. It is said no. Today's concept. There is changing concept. I told you. ATLS is also changing. It is said that tracheobronchial injury is more dangerous, which is not mentioned earlier. Earlier, if you go to the injury chest, you will find what? Pneumothorax, pleurisy, multiple fractures, and repeating to them. And pleurisy is said to be very dangerous. No, it is nowadays you realize it is not that dangerous. What is more dangerous? If there is injury to the tracheobronchial tree, it is more dangerous than that of the other dangerous. So if the tracheobronchial tree is already being injured, then this sort of your treatment is not going to help because your tract is which is going your way is damaged. So whatever measurement you are going to take is not going to help. Yes or no? So this new concept are coming out. So it is not the ATLS which is taught 5 years back is standing today. Concepts are there, but new additional things are there. Like tenosonic acid, as I said, platelets. There I said also anti-drugs in context to the bleeding, where we may be having some anticoagulant drugs. Yes, this point should be open your mind. So you are addressing only focusing that point of a mechanical point of view, probably you may not be able to save the life. So these things are nowadays coming out. Or this is additional medical assisting place from respective laboratory. So once you are there, say nowadays since you are a hospital, so that is why putting the cannula it is said you take the samples also. Particularly if your hospital is there, then ABG. I say your gas analysis is important. Number one. Number two, at least what? Another thing, blood grouping. Blood grouping is everything. Hemoglobin is not very important. Some other tests are also nowadays being emphasized, but basic things are there. So gas analysis is very important, and another thing, your blood grouping. So that sample should be taken immediately if possible, because you are putting in it, blood is coming, so that will help you to do further. You don't need to go for another prick. So same will do all the purpose. Since you are in hospital, so you are in hospital, patient is in hospital, that advantage should be taken. So new things. Okay, primary survey, that is what, as I say, this point you already said. That is why primary survey is not. It is the resuscitation and research. Survey, I told you, airway point already being covered. Many airways is cervical spine motion. It is said, restriction of the cervical motion, no. It is said, limited cervical motion. Time is also changing now. It is not exactly your inline, your tube is given, but the concept is that you rigidly fix it is also not coming. It is rational. You have to be rational in the movement. Because sometimes in the intubation or routine, there will be some sort of movement. There is some sort of singered and also important. Say, while you are doing so, there is some sort of movement there. It is not absolutely true. Absolutely, they cannot keep everything perfectly. Because while you are doing the sucking and routine also, and also putting in a tube, some sort of movements are there. So it is rational. So breathing ventilation, as I said, what you look for? You look for a sex expansion, you look for trachea, you look for the varicose neck veins, you look for uniform expansions, whether one side is there, one side is not there. That is your look for. And what additional thing one should do? One should also, since in the hospital, pulse oximeter, to see the only breathing is not there, whether circulation is going on or not. So that should be confirmed only when there is oxygen saturation is good. Or otherwise, what I said, that it is analysis. Then you will see what is the oxygen percent and what is your carbon dioxide. If the carbon dioxide is coming out, it is good that is actual exchange of gas is taking place. So these are the new things are coming out. Yes? So know exactly that they do not adhere to only old concept. Since things are improving, situations are changing, you have so many gadgets are available now in handy. So take the advantage of that part. It is not only the same old concept. Principles are same, but you have to add and modify according to the availability. Get my point? So these things are also coming up. Right. Circulation, hemorrhage, as I showed, hemorrhage, not only the mechanical point of view. Yes? So you have to expose the patient, exposure, hemorrhage particularly see. If the patient is stable, okay, fine. If he is not stable, then you have to find out where from it is coming. First is going to help you to do the diagnosis for internal hemorrhage. Equally, you have to look for the patient in exposure part, we talk about. The time the patient is see from the back, if there is stab injury, any sort of injury, where from the bleeding is coming. Yes? So two things are in circulation and hemorrhage, then you have to two things. One, fluid is given, then monitoring the patient, then patient whether it is stable or not stable. Not stable means somewhere leaking. Either internal or external. External can be seen from the exposure of the patient from the back. Front you have to expose. Yes? But another point, as I said, that he may be having some sort of your anticoagulant drugs. That is it. So here you have to give anti-drug against the drug. Otherwise morbidity is high. So new thing. ठीक है सर? New thing. So exposure, as I said, visibility, circulation, as I said, is important, and ultrasound is also playing a very important role, as I said. This ultrasound, earlier days it is focused to certain area, heart, lung, liver, spleen, and internal hemorrhage. Nowadays it is extending up to chest, and also cardiac, pericardiac disease, because the cardiac tamponade is another thing. Yes, sir. So these are should be focused, and also look for the pelvic area, where is there any injury to the pelvic organ or not. So that is extended fasting. Disability actually basically neurology. As I said, this is coming only those patients who is unconscious or something like that. Yes, but those patients who is coming walking and talking everything fine, consciousness is there, no point of doing so. So this is where Glasgow's Coma scale. You all know EVM, so that will be done and categorize these patients according to EVM. So you have to find out where from the neurological deficit is. And it also includes the part of your any fracture and anything else. If any fracture from anything, they have to find out and they have to immunize the patient. Exposure is important to, particularly, this exposure is mentioned particularly for the back. In the front you have seen something. You can open up the, while you are looking for the bleeding, you have to open up the cloths. While you are examining the abdomen, you are opening up. And the sharp pain you can open up. But many times the back side is not exposed. And probably there will be injury in the back, which is the culprit of your circulation. So that is why exposure. And in exposure, while we saw it is log rolling. So you do not know the spinal status of these persons. If you are standing your body first and then leg part later on, there will be twisted injury at this injury side. Suppose the L5, L1 is injured. And you are turning the body on the front part, upper part, and the lower part later on. So there will be twisted injury. So log rolling is the ideal choice from you need 3-4 persons. So at a time you are rolling it so that unnecessary movement is not taking place at this spine, which is a dangerous situation. So that is why one should do log rolling to see. And this is, as I said, mostly to see the back. Expose everything. But what thing you should take care? The important thing is to take care. Patient should not be exposed to a very cold climate. I mean, it's a cold environment. So if you are doing so, you are losing temperature, heat, and this leads to hypothermia. So one should have an immediate blanket to cover it. So hypothermia is a dangerous thing. So hypothermia should be prevented at any cost. Or you can have a warm environment, or otherwise you have to take care also. So exposure is allowed, but you must take care for the hypothermia. So these things, as I already told you, already mentioned, these are certain maneuvers are there. So see, if in this maneuver, see, there is some sort of movement of the spine is also taking place. Yes, it is true that absolutely you cannot do it anymore. It is not possible. There is some sort of movement, but you have to inline the unnecessary movement should be there. So these are the manual things you are doing. These things nowadays being, what is the new advance in this here? Anybody who can tell me what is the new advance in this technique? It is called video laryngoscopy. Or you have video into it. That means, what is happening? That many times, what is the problem? While you are putting it there, where is the mistake? It will go to the esophagus. Mostly goes to the esophagus. While you are putting it, mostly go to the esophagus. That is the point. So that is why you are putting the air, and how do you see? How do you confirm it? Whether you have PVC lung or not? Auscultation. Another, also look for the abdomen. If you are putting gas and find your abdomen is giving sound, that means you are in the wrong track. Get my point? That is how they are confirming. Nowadays, no. Now the latest thing is coming up. The laryngoscope have a video which is skinning. So once you are going to it, you can see where you are. Are you in the trachea or you are in the esophagus? Yes? So that recent advance is there. So it makes me things more easy. Mostly here, what happened? That you may not need to do the more manipulation. Many times you may need to see. Yes or no? For seeing you have to align it. But video is showing you. So I think it becomes more easy. So there, what advantage? You do not need to do much movement in the cervical spine. Yes? So that is another additional things are now visible. So this is a video assisted. So that is why one can see in the skin also. You can see what is going on. So where you are you in the trachea or you are in the esophagus? That is the another additional thing. So thereby you are 100% sure. On the other hand, also you are not doing unnecessary movement of the cervical spine. New things. So okay, these things are as I mentioned already. We have to do. The oxygen should be started early. Then also equally you have to go for the pulse oximeter assessment. Yes, then whether your is responding or not responding, whether your job is over or not. So pulse oximeter is another thing to tell you what is the situation there. Yes, sir. Breathing and ventilations. This is as well. This is not very easy nowadays. But what is more not mentioned over here is your tracheobronchial injury. It is more important, more dangerous. Yes, tracheobronchial injury will say their tract is damaged. Tract is damaged. If the tract is damaged, even if you address this part, open your trunk, is it going to help you? Certainly no. Certainly no. So that is another thing. So another thing which is not been mentioned earlier, not given attention to it, is nowadays coming up in number one. And this thing which was thought to be very important, say no, it is not very important. It is not going to kill the patient. But tracheobronchial injury. Yes. So circulation and numerous, as I said, all these things important in and out, as I mentioned. But do not try to address these solutions with only fluid. Another thing. How? You have to address it if in hospital blood or blood products or blood. Sometimes you may go for platelet also. So that is only mechanical thing. But as I said, other things also consider. Just whether he is on some medications or not. So these things, know that it is a new thing. You must understand the point. Next, disability, as I told you. This is important and one should understand and exclusions, as I said, if he can talk, he can orient it, well and good. If no, these things you have to understand. Next. So exposure, as I said already, very important. Important is this. See, so many people are there at a time. 1, 2, 3. Step 1. So this is very important. This is basically to see the back and not doing any damage to the or injury to the spinal cord or spinal cord. Yes, so that is very important and always take care of it. If not possible, you can take the help of the attendant also if you are a limited person. But unnecessarily, you should not try yourself alone. That is another thing. That is problem. Now, exam to the primary survey. What is the exam? As I said, primary survey and resuscitation goes together. And since with the advancement of technology, availability of different gadgets, take the advantage of it. The oxygen saturations, the technical intubations, the control of bleedings are all important things nowadays. I jump to it. Yes, so these things should be also taken care of and should understand. And next thing, as I showed you earlier days, this was not there. The another thing coming up nowadays. Maybe in next generations, what will they will pass the persons. So if you put the patient for C-section, pelvic at least 10 minutes time, 10-15 minutes time, because you have to go for exposure and then to leave. So in next generation, what you will do? You will put in through a quick CT scan machine. Next generation. Then this CT scan will tell you everything. First slice from brain to pelvis. This is already in existence. This is already in existence. What I am talking is oxygen in certain hospitals. It gives better result. Many times your access, as I said, you have very quickly done, not properly done, exposure is not good, and you do not rely upon it. Quality is very poor sometimes. The quick survey access are many times misleading also. Problems are there. And in cervical spine also, how many access are there? You need AP, lateral, oblique, right, left oblique, then also your mouth open view, then your swimmer are there. After that also you are not happy. So now happiness is coming with that simple thing. If the person is being pushed through a machine, here entry, that side is out. So within 5 minutes everything is here in picture. So these things are coming up. Probably in next generation kitab book, you will get this thing abolished, then you will get quick CT scan. And that will be done from head to pelvis, mainly. So everything is done. যাব লাগিব নি Virendra to জাগে যা আকৌ গন্ডগোল হৈ যাব you start and coming yes sir secondary survey as the basic principle of secondary survey is to exclude any minor injury from top to toe. This is done only once the patient is stable. Primary survey is over, then you go for secondary survey. It is not that you are cut off this primary and go for secondary. No. Primary survey is over once the patient is stable. And as I said, that if you are having 3 groups of people doing A, B, C, then while A is established, A will say, yes, my job is over. And B said that my job is over. C said that my job is over. Yes, that is how it is being done. This is a coordinated way. Okay, he will declare that my job is over. When establishment of the airway is done, then the breathing is all addressed. B. C. Circulation is addressed. So that is how it is being done. Yes, then and then you go for the secondary survey. So secondary survey, do not jump. There is no point. And sometimes it can be delayed also. Because a spinal injury or a flexor tibia or ankle injury or finger injury is not going to kill the patient. But necessarily it will kill if the airway is not maintained properly or is fluctuating or his BP is fluctuating. So that is one. That is why secondary survey it is the complete, and there also you have to assess the patient. Certain new additional information should be collected. New additional information are this. You are going to give some medicine. Do you have any history of allergic to him? It is important because you are going to start some medicine, some antibiotic, something. He is allergic to some medicines. If you are studying the underlying problem there, that information is important. Then medication kind use. What medication is on? Cardiac. Many times patient may be having some cardiac problem or respiratory problem, some other medications are there. And certain medications are contraindicated to certain medication. Yes or no? So antagonistic drugs may be used. So that should be again taken care. That is why it is important. Then again comes the past illness of pregnancy. Pregnancy is important because pregnant lady, pediatric one, geriatric one, these are special category of person. Pediatric, geriatric, pregnant ladies are special category of their attentions and focus are a bit different. Although the principles of treatment are almost same, but this calculation of medications and care is a bit special in case of pediatrics, geriatrics and pregnant. Yes? Pregnant. So last point again, this is also important because also if you are talking to patient for OT or whatever it might be, when is taken? Is emptiness there or fullness is there? If fullness is there, regurgitation something is there. You may be coming in as a case of your aspiration also. These things are important. So even environment related injury is important. Why? Because what concept was there? Whether it is a fall injury, whether it is making an accident, you can make out. Whether drowning case, whether he is a victim of explosions, or whether he is a victim of fire. So these things are also important. You can make out. If person is falling, you can know what are the possible injuries. If he is exposed to explosions, persons, if that concept is different. Line is you have to make out the difference. So whether he is exposed to the fire injury. So these things are different. This is also lead to final treatment. Any secondary survey, the pulmonary injury, thermal injury, hazard injury, these are from the history. How he is being exposed to this trauma. What type of trauma? Whether it is a blunt, whether it is sharp one, whether it is a blunt, fire, whether it is a thermal or hazardous. What hazardous mean was? What hazardous mean was? He may be exposed to the nuclear one. Who knows? He may be exposed to the chemicals. So this is hazardous. The hazardous for you also. So hazardous environment is unconditional one. So toxic environment, he may be exposed to toxic, he may be exposed to your nuclear weapons in days to come. Who knows? So these are these are called special environment. So physical anatomy during the second survey is actually basically from head to toe. Systematically you have to exclude and find out any sort of small injuries hidden, which are not dangerous enough to kill him, but you cannot. You have to have a very documentation what are the type of injuries he is exposing. From head, cervical spine, chest, abdomen, perineum, vaginal examinations, rectal examinations are also part of it. So find out if there is a bleed coming from, then you have to be excluded. And in the exam, actually one should what in primary survey now in hospital catheterizations part of it. So you know the catheterization is important to know how he is passing urine. And if he is passing, then what is the rate of your passing urine? That also tell you about his recovery rate, circulations. Yes, that is also another marker for you. The patient is stable or unstable. Urine output, remaining blood stable, blood BP stable, or pulse rate. These are the markers to tell us, indicator or to tell us the patient is stable or unstable. Because there are few things are coming again. And then physical examination, what is the spinal cord examination throughout the course? Early consultation, neurosurgeon, orthopedic surgeon important. Then secondary survey. Now what definitive treatment he need? Then you have to consult the person concerned. Whether you need a surgeon, orthopedic surgeon, whether you need a neurosurgeon or what. So that is your secondary survey. Yes. Exam to secondary survey, there are various investigations being done. These are advanced. Earlier one basic. This is advanced. Whether you may CT scan, you can MRI, you can angiography, you can another concept investigation, bronchoscopy. So this is exam to your secondary advanced one. So this is being done once the patient is stable, otherwise no. So initially things are different. Cervical spine, PAV, chest, pelvis. Here things are different. Here thorough. Whether is there any injury or not. So CT, MRI, angiogram, ultrasound, all these things will be done. Next. So re-evaluation is important in the sense the patient may be stable, unstable again. He is being fluctuating one. Then there are three things may happen. One who is okay, fine, stable. Under is stable, now again unstable, stable, unstable, stable, unstable. Yes, that point need to be monitored. And monitoring criteria, as I said, this is urine output, then ABC. These are the very important things. And this will tell us how this system is working now. Yes, these are the evidence, pulse rate, BP, urine output. These will tell us the patient is stable, unstable. And there are three things are there. One is stable, fine, everything is okay, one good. Another unstable, stable, coming down again, again improving, again deteriorating, undergo. Undergo is called non-responder. He is not responding to it. You are giving so many fluid, then you have to give special attention to the persons. What is the problem? Non-responders. Another group. So accordingly you have to. That can be just with the help of your various parameters. Parameters nowadays laboratory investigations are particularly look for the acid gas analysis of the blood. So definitive treatment, as I said, this is done after secondary survey. So once the patient is stable, then you have to go to definitive. Flexor femur, address it. Flexor patella, address it. Flexor rib, address it. Flexor pelvis, address it. Extradural hematoma, address it. So that is called definitive treatment. So that is done only after secondary survey is over. Patient is stable. Now diagnosis is being done. Then put the patient for operations or whatever will be treatment to give the definitive treatment. That definitive treatment is possible in-house in your hospital. Not possible, then you have to send it. While sending, you are supposed to give a detailed history of the accident, what medications you have given during the period of time. All the information should be given. And today, since you have the telecommunication advantage, you have to communicate whether the doctor concerned is available or not. At what point of time you should send, whether he is ready to welcome this patient or not. Otherwise, it will waste some time. So take the help your advantage of this your informations and passing the information beforehand so that they are also ready that this person is coming. So do not waste any time. So accordingly they can act. So that is to be done. Actually communication to the person, just writing it and referral is not enough. Referral along with all the information, what medications, what maneuver, what thing you have done during the period of time, all the information, and what hospital he should go and who to contact should be communicated. That is your job. Thank you. This is okay. That is